this, we're taking 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 with a pinch of salt.
Dear ERA community, is it possible to be in a dark room and have fun while everybody is outside in the Stockholm Venue Center attending an amazing ERA Congress? Well, it is. If you are in this dark room and have a chat on interesting subject with an eminent specialist. I'm Dr. George Kosmadakis, nephrologist from France, and you're today's host of the podcast A Pinch of Salt. I have the honor and the pleasure to exchange with Professor Mark from Glasgow, UK, the Deputy Chair of the European Renal and Cardiovascular Medicine Working Group. He's a specialist on the cardiovascular implications of renal disease, with over 250 publications that have been cited over 11,000 times. He has participated in a series of national and international guideline committees on this subject. Cardiorenal crosstalk was always an undeniable issue, but lately we have been witnessing very important developments in the vision of the mechanisms and the treatment of the combined associated cardiorenal entities. It seems that an affected kidney sooner than later will affect the heart and vice versa. Dear Paddy, we thank you very much for sharing your time with us today, especially when all these amazing things are happening in the Congress halls at that moment.
Well, thanks for having me, George. It's great to be here. So I've actually just arrived at the Congress, so this is a great way to start. Thank you for the very kind introduction.
Thank you for being with us. We were thinking of a podcast on cardiorenal syndrome for the confused nephrologist, young nephrologist. Things are going so fast lately. The number of therapeutic agents with combined cardiovascular and renal beneficial effects is ever increasing, and the importance of cardiorenal interconnection even more accentuated by the time. And I will start with an obvious naive question that might be not so naive. Why nephrologists should care about the heart?
Well, I think that's the easy one. The rest of the questions you've got lined up for me are much harder, but I think we'll start with the obvious thing that for nearly all our patients with chronic kidney disease, they're for people who are not on dialysis, they're more likely to have a cardiovascular event or even cardiovascular death often than progressing towards dialysis. And then when we look at our patients who are receiving dialysis or with kidney transplants, cardiovascular disease is certainly the leading cause of death in people on dialysis. And in most registries, cardiovascular disease remains either top or very close to top of causes of death in people with a functioning renal transplant as well. And moreover, we're not just talking about cardiovascular death, we're talking about premature cardiovascular death, people losing years of life. And we've known this since the registry studies from the US RDS by Foley and going back 25 years now. Things have changed. There's lots of new interesting therapies and exciting therapies, but it still remains the leading cause of mortality and morbidity really across the spectrum of CKD. And for coming back to the cardiologists, I think finally we're getting there with people recognizing that CKD or chronic kidney disease, CKD, is a major risk factor for future cardiovascular events. I think that's finally coming through loud and clear. We've known it for a long time, certainly good data on this for 10, 20 years, but it's really coming through now to the cardiologists being aware of that as well.
So nephrologists are becoming a little bit of cardiologists by the time, and cardiologists vice versa.
We're starting to have some influence, And I should also just say, I said CKD, clearly albuminuria as well. Proteinuria, albuminuria again is finally shining out. It's a cardiovascular risk that's finally getting there. Yep.
Things are moving. Well, I would like you to tell us a little bit about this initiative concerning the American Heart Association Cardiovascular Kidney Metabolic Syndrome proposal.
Yeah, so I guess we start with this term that we've been bouncing around, cardiorenal syndrome, which goes back historically to, well, it was used a lot, but probably a big paper in JACC in about 2008, and we had all these cardiorenal things. But now I think the new CKM, or cardiovascular kidney metabolic syndrome, which was proposed in a very large review article on behalf of the American Heart Association last year, it kind of looks at things differently. It recognizes, as I've said already, that kidney impairment, CKD, albuminuria is there as a risk factor. It also takes a kind of life course thing from early risk factors, which would be genetic or early life, poor poor health status, lack of exercise, obesity. So almost like a pre-disease where there's much risk factors, and then going through the various stages. And I must say, I'm not using these stages in my clinical practice to actually, you have stage 1 CKM, but in theory you could, but you move from this course of pre-disease to risk factors, which would be albuminuria, hypertension, obesity, to then established disease, which I think they're calling CKM stage 4. But this, and you can use this approach to both screening or recognition of disease and then thinking about therapy. I think they're two different things, but nonetheless, it is. I think it's great because it's a welcome initiative. It's it's coming from AHA, which we're in Europe, but we have to at least acknowledge AHA as one of the major, guideline writing, advocacy organizations in the world in cardiometabolic health. So sure. So I think this is really welcome to see this, and it seems to be coming through. I mean, I've been at a few international meetings since people are talking about it. So it's changing things.
It's changing because cardiorenal syndrome was it's a clinical entity. And it's too late when you start talking about it.
Yeah, so this is getting earlier. Yeah,
this is starting taking some distance, and it's a little bit more preemptive, more early stage of.
Oh, absolutely. I mean, the original cardiorenal syndrome, I don't know if you recall, states 5 different subtypes. Whether the primary organ was involved was the heart, or the primary organ was the kidney, but it was all very much disease established. Person with congestion, fluid overload, failing heart, failing kidney, low GFR. This is much more preemptive. It's not a concern, it's just the changing landscape. It's somewhat therapy driven because we now have therapies, where before we had slightly more limited therapy. So I think there's the term paradigm shift gets bounced around, but it gets bounced around a lot of times. But because things have changed, the landscape has changed, both the scientific recognition of causes and mechanisms, but also because the therapies are completely different from where we were 15 years ago. So I think some of this is in response to different therapeutic approaches because we have them, but that's where we are. But I think you're right, it's more preemptive or recognition early because we can now intervene earlier, before symptomatic disease for both CKD. We have therapies for CKD, which we didn't have many. We've now got quite a few, and we also have better therapies for heart failure. We have the four pillars of goal-directed medical therapy, or GDMT as they call it. So we have lots more. We have lots more therapies, which allows us to target people earlier, and we still have to deal with symptomatic disease when it happens, but we've got lots more to offer. So we need to increase our efforts, and hence maybe a redefinition and a rethink was needed.
Well, you said the redefinition. How can somebody define the cardiorenal or cardiorenal metabolic syndrome in 2024? What is the definition? What is the potential classification? How could you?
Well, so the classification. So I did look. I had to do my homework for the podcast. The classification would be on severity of the constellation of disease entities or risk factors, from stage 0, which is you don't actually have anything, but you're at risk. So you would be, if you like, pre-diabetes, adverse metabolic phenotype, inactive, through to stage 4, which would be advanced CKD, G4 or below, or with heart failure or atherosclerotic event prior MI. And stage 1, 2, and 3 are CKD, the increasing stages, hypertension, established LVH, etc. I don't actually think the staging is particularly useful in clinical practice. I think it's reasonable for research studies and epidemiology, etc. But I think in clinical practice, we come back to the old-fashioned recognition of risk factors, and that we can intervene in these risk factors, and that would be lipids, blood pressure, glycemic control, your friend physical activity, and then thinking about what we can offer. And we have drugs, for example, which can now target BMI. And we'll be hearing data presumably later on today at this Congress about flow. I have no idea what it's going to show, but there's clearly going to be increasing data for all these things. But I don't think the staging at the minute in 2024 is easy to do in clinical practice. I don't think it rhymes off my head. But let's see. Maybe in 2 years' time I'll be wrong and people will be classifying people.
I remember, the classifications, acute or chronic,
Yeah.
and initial problem, cardiac or renal.
Yeah.
And
So I learned that off by heart in 2008 when it came out, and I was there was stage 1 was acute heart failure causing kidney dysfunction. I can't remember if 2 was. I remember 4 was really CKD causing, what we see as nephrologists, CKD causing LVH, etc. Stage 5 was multi-system. It never really came into clinical practice, although it was a good way of thinking about things. And I'm not sure that CKM will translate. Certainly, although interesting for researchers, whether that ever gets to primary care physicians, etc. I'm not sure, but let's see.
Well, it's very interesting that what you say, because nephrologists do not. They are conscient concerning the causes, and they find it very natural that sometimes in acute cardiac failure you might have a degradation of the renal function, which is very stressing for the other specialties and the GPs, and we have very often patients who are referred to us in an urgent manner because there was some cardiac problem that has provoked renal dysfunction, and that's why I wanted to ask you, which is the landscape for the treatment of cardiorenal syndrome?
So I think the big thing, because we now have therapies, and a lot of the therapies are now overlapping. And if we go back to sort of what I mentioned, this goal-directed medical therapy, which has come from heart failure, and that was a concept which was probably, I think GDMT was described by my colleague John McMurray a couple of years ago. He's a cardiologist in Glasgow. But we have the same, we have what I like, goal-directed medical therapy, which we should be using in CKD, and we're talking about non-dialysis CKD. But we have the therapies overlap, which means that they work for both kidney disease, but also for cardiometabolic disease. So let's start. I'm going to be naughty and go in the wrong order and start with the SGLT2 inhibitors, because I think they're probably more exciting. They've shown this big leap forward in therapy, but that should always be on, at least with a goal of being on the background of renin-angiotensin system inhibition. But we have, if we take RAS inhibition as standard, we have SGLT2, and then looking at the kind of full cardiometabolic phenotype, if we're talking about diabetic kidney disease, we have finerenone. For heart failure, we would be waiting for the Fine Arts trial, which is a couple of years away before we know that one.
What is this trial?
Oh, Fine Arts. Sorry, Fine Arts is a trial of, it's like Fidelio, the trial of finerenone. So there's Fine Arts is a trial of the same drug in heart failure patients. So the baseline study, the baseline characteristics paper is just out last week.
Okay,
sorry.
So
yeah,
it's
but
finerenone for patients with
diabetes and proteinuria as well. We have SGLT2 and we have renin-angiotensin system inhibition. What we don't know yet is where we will be tomorrow, whenever we have more data from flow, and where GLP-1 agonists sit with this for the kidney side of things. There's data with GLP-1 agonists now in people with obesity or high BMI and heart failure, which come out. I'm not the expert on that, but my colleague Mark Petrie, who's again in Glasgow, the cardiologist, has led some papers on that. But we've got there's a variety of classes of drugs: RAS, SGLT2, non-steroidal MRA, old-fashioned MRA, or mineralocorticoid receptor antagonist for people who've got better GFR. So we've got a lot of drugs, and I'm not I've not even talked about the other things which should be part of our standard considerations, such as lipid-lowering therapy, aspirin for people who've had atherosclerotic events, and back to we can't forget lifestyle or non-pharmacological interventions, whether that's physical activity, healthy diet, low sodium, etc. So we've got a lot more to offer, and maybe I'm talking at length, but I've been lucky enough to be involved in a couple of the KDIGO controversies conferences in this area, and I looked at the paper from the controversies conference on heart failure and CKD, which came out in Kidney International in 2018, and it was extraordinary because there's so few therapeutic options in that paper because none of the SGLT2 studies were out at that time. And then I've just come back from the updated KDIGO controversies conference on this area. I'm sure there'll be a paper next year about this. When we were talking, with SGLT2s, with GLP-1, it's just astonishing thing in 5 years we've suddenly got a load of new therapeutic options. But we mustn't forget lifestyle as well.
So the advice you are giving is that we should not forget the standard of care, which is the non-pharmacological interventions, or this intervention that you stated, the standard pharmacological interventions, ACE inhibitors, angiotensin blockers, statins, probably anti-aggregant treatment for certain patients, and we have the new kids on the block, SGLT2, MRAs.
Yeah, I think it's worthwhile particularly for the SGLT2s to think that we shouldn't wait until, as long as there's an indication, we shouldn't wait until people are way down into the symptomatic advanced CKD, advanced heart failure, whatever. Often there's often an indication. Start early. As I say, implementation, not hesitation. The first doctor to realise that these therapies are required should be the person to start them. If it's a primary care person, I would hope that they would think, gosh, I need this therapy, this patient needs this therapy, rather than waiting to refer to cardiologist who then has a think and refers to nephrologist. First person to realise, first person to start. Most of these drugs are easier to use and require slightly less monitoring than ACE inhibitors with potassium checks all the time. So,
There was Professor Coca in the Society of in the Congress of the American Society of Nephrology, and he said, I will paraphrase a famous dictate: ask not yourself where you can prescribe SGLT2 inhibitors. Ask yourself where you cannot prescribe SGLT2 inhibitors. Because, he was talking about this huge number of indications.
Yeah, well, that's exactly it. I think and if you look across the trials, you could look at which you like best, EMPA-REG or DECLARE for earlier disease or symptomatic disease, but not lots of risk factors, down to patients with impaired left ventricular function, which would be DAPA-HF or EMPA reduced, or you can look at your CKD indication and you've got your cretins with canagliflozin, or EMPA kidney with empagliflozin, or DAPA CKD. There's indications across the spectrum for the SGLT2, and then we have finerenone for diabetic kidney disease. But it'll be interesting to see where the indications appear for GLP-1, whether they just plug into the same things. Let's see.
And probably they are talking about synergic effects between all these.
I think so. And but I think the other thing is it's exciting. We have to be cautious of this, but it's exciting that not only have we evidence, but we also have pharma, new therapeutics being considered and new trials coming along all the time. We had a long time coming to these congresses where we didn't see very much new stuff. Yes. And now we feel a little bit like the cardiologist or the oncologist, where everything is new, it's a breaking trial and things like that. I don't say the young guys are spoiled, but it's an exciting time to be a nephrologist.
Yes, you younger nephrologists, I can assure you, a few years ago there were congresses where we were living exactly as we came.
Yeah, exactly.
And now exciting things are happening.
Yeah, we had observational data in the breaking trials session because there were no breaking trials. Now we've got breaking trials. We sometimes have people standing up and applauding trials. That's cool.
Applauding trials, yes. We did have this before.
And we should say it's not because it's new evidence for our patients. Going back to where we started, it's pretty tough having CKD. The outcomes are still not where we want them. So the fact that things are continuing to improve and incrementally improving on top of therapies is just, it's an exciting time for our.
But that's why we're doing this kind of podcasts, because we see that things are really going fast.
Yeah.
And well, thank you very much. And now I will ask you the two typical questions we're asking all our guests. If you were in a desert island, which book, luxury item, and 2 songs would you take with you?
So I've escaped all the scientific questions. So the book. So I obviously I thought about these answers before I looked at the science. But so the book, I would probably go for Moby Dick by Herman Melville. It's a big book. I've read it once, and if I'm on the desert islands, I'd read it again. It covers it. It's pretty wide. It covers a lot of big issues, and obviously saw a lot of things. So I'll take Moby Dick. Luxury item, bicycle. I cycle to work, I guess. Depends what the desert islands roads are like. I'll take a bicycle. And for the songs, so I've a lot of jokes. So this is my summer of live music. I was a day late to the Congress because I made a mad road trip to go and see Bruce Springsteen. So I'll take Thunder Road by Bruce Springsteen.
Right.
And I'm a dad of teenage girls, so I'm going to see Taylor Swift. So I will take. So I'll take of the many Taylor Swift songs that my colleagues know I love. I'll take Wildest Dreams.
Perfect. You know, we are going to do a playlist very soon with all the songs chosen by our guests. Now we know we are from Glasgow, Macintosh town, and would you like to tell us something about Glasgow?
So I'm not sure if I'm allowed to say yet when this podcast comes out, but I think Glasgow will be having a European Renal Association at some point in the near future.
Oh,
maybe. So I'm hoping so. Let's
that's
say.
a scoop.
Yeah, it's a scoop if it's true. Yeah, you can edit it out if it doesn't happen. So I'm originally from Ireland, but I've lived in Glasgow for all my professional life. It's a really friendly place. It's an industrial city, but it's really friendly. It's got good nightlife. It's got good eating out, and it's. I'm not going to mention which team, but it's probably got one of the greatest football derbies in the world. It's Celtic Rangers. It's 2 epic historical football teams. So it's a mad football town.
Perfect. I love this town. So, dear colleagues, I hope you enjoyed, as I did, this wonderful exchange on cardiorenal syndrome. It is there. It is more often and more important than you think. Search for it, identify it, treat it as best as you can with the important insights proposed by Professor Mark today. Paddy, thank you so much for being with us today. A lot of other Pinch of Salt podcasts on a wide range of subjects have already been released, and many others will be released in all the main social media platforms. Do not hesitate to check them out. Thank you.